Welcome to the Certified Inpatient Coder course Part 1, which is updated for the year 2026. Are you worried about passing the big coding exam, or do you feel lost with the thick books? I am here to help you understand inpatient coding, so you can pass this test with flying colors. These questions come with full explanations, which will help you get your certification on the first try. Please leave suggestions in the comment section below, so I can improve this course for future students. We are now beginning section 1 of this course, which covers the basic rules of medical inpatient coding. We will start with the basic rules of inpatient coding, because this is the foundation of your job. Inpatient coding is very different from outpatient coding, mostly because we focus on the principal diagnosis heavily. The principal diagnosis is the main reason for the stay, which is determined after the hospital discharges the patient. You must read the entire medical record carefully, so you can find the true reason for the admission. Sometimes the doctor is not very clear in the notes, which means you might need to ask them questions. We call this process querying the physician, and it helps make sure the coding is perfectly accurate. ICD-10 codes are used to show the diagnosis, which tells the insurance company what is wrong. We also use ICD-10 PCS codes for procedures, which show exactly what the doctor did to help. You need to know how to use both codebooks, because the exam tests you on both systems. Let us talk about secondary diagnoses in the hospital, which are other conditions the patient has right now. These other conditions must affect patient care somehow, like needing more medicine or making the stay much longer. If a condition does not affect the current stay, you should not code it on the final bill. A very big part of the test is coding guidelines, which change a little bit every single year. For the year 2026, we must pay close attention to new codes for infections and diseases. I want you to highlight your code books nicely, so you can find answers fast during the exam. Remember that coding is like solving a fun puzzle, where you match doctor words to specific number codes. We read the history and physical exam first, and then we look at the discharge summary for clues. The discharge summary is the most helpful document, but you still need to read all the daily notes. Sometimes a patient comes in with a big problem, but the doctors find a worse problem later on. In this case, the principal diagnosis might actually change, depending on what the doctors spent time treating most. You always code the condition established after study, which means looking back at everything after the patient leaves. Now we need to talk about present on admission indicators, which we simply call POA for short. This indicator tells the insurance if the patient already had the problem before they walked into the hospital. If they caught an infection while staying in the hospital, the POA indicator will show a different letter. Hospitals do not get paid extra for hospital-acquired conditions, so getting the POA right is super important. We use a letter Y for yes it was present, and a letter N for no it was not. We use a letter U if we just do not know, and a letter W if the doctor cannot decide. Medicare uses a system called diagnosis-related groups, which groups similar cases together to figure out the payment. We call these DRGs for short in the coding world, and your codes decide which group the patient gets. If you pick the wrong principal diagnosis code, the hospital might lose a lot of money they earned. This is why inpatient coders are so highly valued, because they protect the financial health of the hospital. Train, test, we need to fix. Repeat the process until you are perfectly ready for the real exam. Let us move on to the practice questions now, because testing yourself is the best way to learn fast. 1. What is the definition of a principal diagnosis, according to the official inpatient coding guidelines we use? It is the condition established after study to be chiefly responsible for occasioning the admission of the patient. The doctors must figure out the main reason for the hospital stay, which happens after all the tests. 2. Which code set do we use to report the medical procedures done inside an inpatient hospital setting? We use the ICD-10 PCS code system for all procedures done in the inpatient hospital setting. PCS stands for Procedure Coding System, and it is built specifically for hospital stays and major surgeries. 3. What does the present on admission indicator tell the insurance company about the patient's medical condition? It explains if the patient already had the sickness before they were admitted to the hospital bed. This helps the hospital track conditions that started during the stay, which impacts how they get paid. 4. If a patient comes in for surgery but it is cancelled, what should be the principal diagnosis? You must code the reason the surgery was originally planned as the principal diagnosis for the stay. Even if the surgery did not happen, the reason they came in is still the main medical focus. 5. How do you code a diagnosis that is listed as possible or probable at the time of discharge? You code the condition as if it exists or was established, according to the inpatient coding rules. Inpatient rules let us code uncertain diagnosis at discharge, which is very different from the outpatient coding rules. 6. When two conditions both meet the definition of principal diagnosis, how should the coder choose the right one? Either condition may be sequenced first, depending on the specific circumstances of the patient admission and treatment. You can pick either one as the main code, as long as both would treat equally during stay. 7. What is the main purpose of the diagnosis-related group system used by Medicare and other health insurances? It groups similar medical cases together, so the hospital receives a set payment for that specific hospital stay. This system makes hospital billing much easier, and it prevents overcharging for common procedures and medical treatments. 8. If a patient has a chronic condition that is not treated during the stay, do you code it? You do not code conditions that have no bearing on the current hospital stay or medical management. Only code things that require clinical evaluation, extra treatment, more testing, or extend the overall length of stay. 9. What should a coder do if the doctor's notes are missing important details about a specific diagnosis? The coder must send a query to the doctor, so the doctor can clarify the missing medical information. Guessing is never allowed in medical coding, so asking the doctor is the only safe way to code. 10. Which document in the patient record provides the best summary of the entire hospital stay and treatments given? The discharge summary provides the best overview of the entire stay, including the final diagnoses and all procedures. This document is written at the very end, so it has the most complete picture of the sick patient. 11. How are external cause codes used when a patient is admitted for an injury caused by an accident? They provide extra data about how the injury happened, but they are never used as the principal diagnosis. These codes explain the event and location, which helps public health experts track common accidents and painful injuries. 12. If a patient is admitted from outpatient surgery for a complication, what is the principal diagnosis code? The complication itself is coded as the principal diagnosis, because it is the reason for the inpatient admission. The original reason for outpatient surgery becomes secondary, because the new problem caused the overnight hospital stay. 13. When looking at the alphabetic index, what should you do before assigning the final code to the patient? You must always verify the code in the tabular list, to make sure you have the exact match. The index is just a guide to help you, but a tabular list has the strict coding rules. 14. What does the term principal procedure mean when you are coding for an inpatient hospital stay or visit? It is the procedure performed for definitive treatment, rather than just for testing or exploring the medical problem. This is usually the biggest surgery or treatment the patient had, which takes care of the main sickness. 15. If a patient transfers from one hospital to another, how does the second hospital determine the principal diagnosis? The second hospital chooses the principal diagnosis based on the condition that caused the transfer to their building. Each hospital stay is a separate event, so the second hospital must evaluate the patient all over again. 16. Can a symptom code be used as the principal diagnosis if the underlying cause is already fully known? You should not use a symptom code as the principal diagnosis if the true disease is already known. We always code the actual disease instead of the symptom, because it gives a much clearer medical picture. 17. How do you code a condition that is described as impending or threatened at the time of discharge? You must check the alphabetic index to see if there is a specific subterm for impending or threatened. If there is no specific code for the threat, you just code the underlying condition that exists right now. 18. What happens if the pathology report shows a different diagnosis than the main doctor listed on the chart? You cannot code directly from the pathology report, so you must query the attending physician for clarification first. The attending physician is completely in charge, so they must agree with the pathology findings before we code. 19. Why is it so important to code all severe secondary diagnoses for a patient in the inpatient setting? Severe secondary conditions can increase the diagnosis-related group level, which brings more fair payment to the hospital. Sick patients require a lot more nursing care and resources, so the hospital needs proper funding to help. Thank you for watching the first part of this course, and I hope you learned a lot today. Please check the description box below this video, so you can get the full course right away today. Train, test, we need to fix, repeat the steps daily, and you will pass the big exam easily. Welcome back to Section 2, where we will learn about coding infectious diseases and nasty tumors. I am so glad you are here, because these chapters are very heavy on the exam. We will talk about sepsis today, which is a very dangerous infection in the human blood. Sepsis happens when an infection spreads, and the body attacks its own organs by mistake quickly. You must look for the underlying infection first, like a bad cut or a lung problem. We always code the systemic infection first, and then we code the specific local infection next. Severe sepsis is even more dangerous, because it means one of the body organs is failing. If the doctor writes severe sepsis, you will need a minimum of 2 separate diagnosis codes. First you code the main infection, and then you use the specific code for severe sepsis. You also need a third code, which tells us exactly which body organ is failing today. Septic shock is the worst kind, because the blood pressure drops to a very dangerous level. We code septic shock exactly like severe sepsis, but we add a specific shock code too. Now let us talk about neoplasms, which is the medical fancy word for cancer and tumors. Neoplasm codes are found in a special table, which is placed right inside your codebook. You must know if the tumor is primary, which means it is where the cancer started. A secondary tumor means the cancer spread, which we call metastasis in the medical coding world. If a patient comes in for chemotherapy, you code the special chemotherapy encounter as primary first. After the chemotherapy code is placed, you will code the active cancer as the secondary diagnosis. But if they come in for surgery, you code the actual cancer as the primary diagnosis. We also have benign tumors to code, which means they are not cancer and will not spread. Sometimes doctors are not sure about the tumor, so they call it a tumor of uncertain behavior. You must read the pathology report, but the doctor must agree with it before you code. Let us move on to diabetes coding, because you will see this disease very often too. Diabetes has many different complication codes, which show how the high sugar is hurting the body. If the doctor writes diabetes with kidney disease, you will use a special combination code today. Combination codes are very helpful for us, because they put two big problems into one number. We assume a connection between diabetes and kidneys, unless the doctor says they are not related. You also need to know the diabetes type, which is usually type 1 or type 2. If the doctor does not write the type, the coding rules say to pick type 2. You must also code the long-term insulin use, if the patient takes it every single day. Some patients use an insulin pump, which requires a totally different code in the code book. Reading the whole chart is your main job, because details hide in the daily progress notes. Do not just look at the discharge summary, because you might miss a very important complication. I know this feels like a lot of rules, but you will learn them with much practice. Train, test, we need to fix. Repeat the process until the rules stick in your brain. 20. What is the very first code you assign when a patient is admitted for severe sepsis? You must assign the code for the underlying systemic infection first, before the severe sepsis code. This rule helps show exactly what kind of bug caused the whole body to become sick. 21. If a patient comes into the hospital for chemotherapy, what should be the principal diagnosis code? The special encounter code for chemotherapy must be placed as the first and principal diagnosis code. The main reason they walked in the door was the treatment, not to treat the cancer directly. 22. How do you know if a tumor is primary or secondary when looking at the chart? A primary tumor is the original starting point, and secondary means the cancer has spread elsewhere. You must read the pathology report closely to see if the doctor mentions metastasis or spreading. 23. If a doctor documents diabetes but does not specify the type, what do you code instead? The default rule tells us to code it as type 2 diabetes when nothing is specified. Type 2 is the most common form, so the coding book uses it as a safe guess. 24. What type of code connects two separate conditions together, like having diabetes and kidney disease simultaneously? We use a combination code to link these two problems together under a single code number. This saves a lot of space, and it clearly shows the disease caused the organ failure. 25. If a patient has sepsis and acute respiratory failure, which condition should you code first today? You code the condition that mainly caused the admission, depending on the specific doctor discharge summary. Both are very life-threatening, so you must look at what the doctors treated the most. 26. What happens if you code severe sepsis, but you forget to add the organ dysfunction code? The coding claim will be wrong, because severe sepsis always requires a separate failing organ code. The insurance company will reject the bill, because the story is missing a very big piece. 27. When coding an HIV infection, when should the HIV code be sequenced as the principal diagnosis? It is sequenced first only when the patient is admitted for an HIV-related illness today. If they come in for a broken leg, the leg injury is first and HIV is secondary. 28. What does the term in situ mean when you are looking at a cancer pathology report? It means the cancer cells have not spread at all, and they are staying right inside. This is a very good thing for the patient, because it means the cancer is easily contained. 29. How do you code an infection that is resistant to the antibiotics given by the nurses? You must use an extra code to identify the drug resistance, right after the infection code. This helps track superbugs in the hospital, which keeps the public much safer in the future. 30. If a patient is admitted to remove a secondary tumor, what is the principal diagnosis code? The secondary tumor is the principal diagnosis, because it is the main reason for the surgery. The active primary cancer is coded as secondary, because it is not the main surgical target. 31. Do we ever use a personal history of cancer code, if the patient still receives treatment? You never use a history code if the patient is still getting active cancer. Treatments today. A history code means the cancer is totally gone, and no more treatment is needed anywhere. 32. How do you code a patient who takes insulin daily, for their type 2 diabetes condition? You assign the code for type 2 diabetes, and add a code for long-term insulin. This shows the insurance company that the patient needs extra supplies to manage their blood sugar. 33. What should you do if a doctor documents urosepsis, but does not explain the condition clearly? You must query the doctor immediately, because urosepsis does not have a specific code in the book. The term is too confusing, so the doctor must say if it is a blood infection. 34. If a patient has cancer and is severely dehydrated, and comes in for hydration, what is first? The dehydration is the principal diagnosis, because they came in specifically to get fluids through wires. The cancer is coded as secondary, even though the cancer is what actually caused the dehydration. 35. What is the rule for coding a systemic inflammatory response that is not caused by infection? You code the underlying cause first, like a big burn, and then the inflammatory response code. The body can get very sick from burns or trauma, without any bacteria being involved today. 36. How do you code a diabetic ulcer if the doctor says it is located on the heel? You use the combination code for diabetes with ulcer, and then a specific code for the heel. This paints a perfect picture of the problem, so the hospital gets paid for the right bandages. 37. When can you code an infection as hospital-acquired, according to the official inpatient coding guidelines? The doctor must document the infection started during the stay, and the POA indicator is N. The hospital will not get extra money for this, because they caused the infection by accident. 38. If a benign tumor causes a severe blockage in the bowel, which code do we put first? You can code either one first, depending on what the doctors spent the most time fixing. Read the surgical report carefully, to see if they removed the tumor or just cleared the block. Thank you for studying the second part of this course, and I hope you are learning fast. Please look at the description below the video, so you can buy the full course right now. Train, test, we need to fix, repeat these simple steps, and you will become a certified coder. Welcome back to section 3, where we will talk about the human heart and lungs. I am very proud of you, because you are working hard to learn these codes. The heart is a big muscle, which pumps blood to every part of your body. Sometimes the heart gets very sick, and the doctor calls this condition heart failure quickly. You must look for the type, which means finding out if it is acute today. Acute means it happened very fast, and chronic means it has been there a while. If the doctor says acute on chronic, you must use a special combination code today. This code shows the insurance company that the patient has a long and sudden problem. Another big problem is a heart attack, which the doctor calls a myocardial infarction. Often, we use the letters M and I to talk about this dangerous condition much faster. You must check the medical record to see if the heart attack is STEMI type. STEMI means the blockage is total, which causes a lot of damage to the heart, Non-STEMI means the blockage is partial, but it still requires very urgent medical care. The coding rules change a lot when a patient has a second heart attack soon. If a new attack happens within 4 weeks, you must use a completely different code. Now let us talk about the lungs, because breathing problems send many people to hospitals. Pneumonia is a very common lung infection, which fills the tiny air sacs with fluid. You must read the lab reports to find out exactly which bug caused the pneumonia. Sometimes the doctor does not know, so we use a code for unspecified pneumonia then. Asthma is another big lung disease, which makes the breathing tubes very tight and narrow. You need to see if the asthma is currently causing a severe attack right now. We call this status asthmaticus sometimes, which means the asthma is not responding to medicine. Chronic obstructive pulmonary disease is common, and we usually just call it COPD for short. If a patient has COPD and asthma, you might need to use a combination code. Always read the doctor notes carefully, because they might link two breathing problems directly together. A patient might stop breathing totally, which is called acute respiratory failure in the chart. This failure can be the main diagnosis, if it is the reason they were admitted. But if a head injury caused it, the head injury must be the principal code. Sometimes patients breathe in bad things, like food or liquid into their delicate lung tubes. We call this aspiration pneumonia today, and it requires a different code than regular pneumonia. Do not confuse the two types, because they have very different treatments and hospital costs. You will read a lot of charts, where patients have heart and lung problems together. You must figure out the main problem, which caused the hospital stay in the beginning. This is why we read everything, from the emergency room to the final discharge summary. Taking good notes will help you when you are taking your big coding test soon. Train, test, we need to fix, repeat the steps until you are a coding expert. Heart and lung codes are very important, so you should highlight them in your book. Let us look at the practice questions, so you can test your new coding skills. 39. What do you code first when a patient has a heart attack and pneumonia today? You must code the condition that the doctors spent the most time fixing today. The principal diagnosis is always the main problem, which required the most hospital resources. 40. How do you code heart failure if the doctor does not mention acute or chronic? You must use the unspecified heart failure code, which is found in the code book. We can never guess the severity, so we must pick the least specific code available. 41. What happens if a patient gets a second heart attack within 2 weeks of the first? You use a special code for a subsequent attack to show it is very new. The rules say any new attack within 4 weeks gets this exact subsequent number code. 42. Can you code a cough as a principal diagnosis if the patient has confirmed pneumonia? You cannot code the cough at all, because it is just a symptom of pneumonia. We only code the main disease, because the symptom is already expected with the sickness. 43. What code do you use if the doctor documents a stroke that happened years ago? You must use a personal history code, which shows the stroke is old and gone. The old stroke is not active right now, so it does not need active treatment. 44. How do you code a patient with COPD, who also has acute bronchitis right now? You use a combination code that includes both the COPD and the acute bronchitis together. This combination code tells the full story, and it is required by the official guidelines. 45. If the lab says the pneumonia is viral, but the doctor says bacterial, what happens? You must query the doctor for clarification, because the chart has two very different answers. Coders cannot pick sides, so the attending doctor must make the final medical decision always. 46. What does the term status asthmaticus mean when you read it in a medical chart? It means the patient is having a very bad asthma attack that will not stop. This is a massive emergency, and it always requires a very specific code to report. 47. If a patient breathes their own vomit into the lungs, what kind of pneumonia is it? This is called aspiration pneumonia, because the stomach contents went into the wrong breathing pipe. This type of pneumonia is very dangerous, and it gets a totally separate disease code. 48. How do you handle a diagnosis of suspected COVID-19 when the patient is discharged? You cannot code suspected COVID-19 ever, so you only code their current physical symptoms. The rules for COVID are very strict, and it must be fully confirmed by doctors. 49. If a patient has acute respiratory failure and heart failure, which one is sequenced first? You sequence the one that mainly caused the admission, based on the doctor discharge summary. Both problems are extremely serious, so the doctor must tell you which one was worse. 50. What do we do when a patient needs a mechanical ventilator for their breathing failure? We must add a procedure code for the ventilator and check exactly how many hours. The time spent on the machine changes the code, so you must count the hours. 51. How do you code hypertension and heart disease if the doctor mentions them both today? You must assume they're linked together and use a special hypertensive heart disease code. The coding guidelines force us to link them, unless the doctor says they're separate. 52. If a patient comes in for a lung biopsy, what is the main procedure code? The lung biopsy is the principal procedure, because they went inside to test the tissue. Biopsies help the doctors find cancer, and they are always coded as AMA procedure. 53. What should you do if the discharge summary is missing when you try to code? You must wait for the doctor to finish it before you finalize the coding bill. The summary has all the final answers, so coding without it is a big mistake. 54. How do you code a heart attack that the patient ignored for over 8 weeks? You must code it as an old myocardial infarction, because it is past 4 weeks. After 28 days pass by, the heart attack is officially considered an old problem. 55. What code do you assign for a patient who smokes a pack of cigarettes daily? You must assign a code for tobacco dependence, because it affects the current lung health. Smoking makes all breathing problems much worse, so it is a very important secondary diagnosis. 56. If asthma is documented as mild intermittent, what exactly does this mean for the coder? It helps the coder pick the exact asthma code, which shows the severity level nicely. The codebook has different levels, so these small words make a huge medical difference. 57. What happens if a patient leaves the hospital against the strict advice of the doctor? You still code the chart normally, but you add a special discharge status code number. The insurance needs to know they left early, because it changes the final hospital payment. Thank you for finishing the third part, and I hope you are feeling very confident. Please look in the description below, so you can get the full course right now. Train, test, we need to fix, repeat these simple steps, and you will do great. Welcome back to Section 4, where we will study the digestive system and the urinary system. I know you are doing a great job, because these medical topics can be very tricky. The digestive system helps your body turn food into energy, but many things can go wrong. You will see many patients with stomach pain, which doctors often call abdominal pain in charts. If the doctor finds a specific cause, you must code the cause instead of the pain. A common problem is an ulcer, which is a painful sore inside the stomach lining. You need to look for bleeding, because a bleeding ulcer is much more dangerous to have. If the patient is vomiting blood, the coder must use a code that shows a hemorrhage. We also see many patients with gallstones, which can block the flow of important digestive bile. The medical word for this is cholelithiasis, and it often leads to a surgical gallbladder removal. You must check if the gallbladder is inflamed, which doctors call cholecystitis in their daily notes. If both stones and inflammation are present, we use a single combination code for both. Now let us look at the urinary system, which cleans the blood and makes the urine. Kidney failure is a very major topic on the exam, and it has different stages. Chronic kidney disease is called CKD, and it goes from stage 1 to stage 5. Stage 5 is the worst, and it is often called end-stage renal disease today. You must code the specific stage, because it tells how well the kidneys are working. If a patient is on dialysis, you must add a code to show this life-saving treatment. Acute kidney failure is different, because it happens very suddenly due to injury or a sickness. You can code both acute and chronic kidney failure together if the doctor documents both conditions. Urinary tract infections are also common, and we call these UTIs in the medical coding world. You must look for the specific bacteria in the lab report, like the common E. coli. Just like with pneumonia, you need a second code to identify the exact infectious bug. Sometimes a patient has a kidney stone, which causes a lot of sudden and sharp pain. If the stone is in the kidney, it gets one code, but the bladder is different. Always check the exact location of the stone, so your code is perfectly right every time. Reading the operative report is vital, especially when the doctor performs a scope or surgery. A scope lets the doctor see inside the body, without making a very large surgical cut. We call this a diagnostic procedure, if they are just looking around to find a problem. But if they fix something during the scope, it becomes a surgical procedure for the coder. Train, test, we need to fix. Repeat the process until you know these organs very well. Let us practice with these questions, to make sure you are ready for the coding test. 58. What do you code when a patient has stomach pain, but the doctor finds appendicitis? You must code the appendicitis as the principal diagnosis, and ignore the stomach pain code. The pain is just a symptom of the appendicitis, so we code the actual disease instead. 59. How do you code a patient who has both stage 3 CKD and a kidney transplant? You code the stage 3 CKD first, and then add a code for the kidney transplant status. Even with a transplant, the patient can still have kidney disease that needs careful medical monitoring. 60. What is the rule for coding a GI bleed, if the doctor does not find the source? You must use the code for gastrointestinal hemorrhage, even if the exact spot is not known. Bleeding is a very serious medical event, so it must be reported on the final coding bill. 61. If a patient has a hernia that is blocked or stuck, what word should the coder look for? You should look for the words incarcerated or strangulated, to show the hernia very stuck. A stuck hernia is a medical emergency, so it gets a much more serious code in the book. 62. How do you code a patient who has end-stage renal disease, and requires regular dialysis? You code the end-stage renal disease, and then add the code for dependence on dialysis. This shows the patient is very sick, and they need expensive machine treatments to stay alive. 63. What code do you use if a patient has a UTI caused by a specific yeast infection? You code the UTI first, and then you add a separate code for the candidiasis infection. Using two codes explains the location of the problem and the exact type of germ involved. 64. If a doctor removes the appendix because it has burst, how does the code change? You must use the code for acute appendicitis with generalized peritonitis, because it has burst open. A burst appendix is much harder to treat, so the hospital needs more money for care. 65. Can you code a diagnosis of dehydration if the patient also has a very severe UTI? You can code both if the doctor treats both, but pick the most severe as principal. Usually the infection is the main cause, but sometimes the dehydration is the bigger medical problem. 66. What should a coder do if the pathology report says a polyp is precancerous? You should look for the code for a benign neoplasm or a polyp with dysplasia. Precancerous is not cancer yet, so we must be very careful not to use cancer codes. 67. How do you code a procedure where the doctor looks into the stomach with a camera? This is called an EGD or upper endoscopy, and it gets a specific ICD-10 PCS code. PCS codes for scopes are based on where the camera enters and how far it goes inside. 68. If a patient has a kidney stone and a UTI together, which one is coded first? You code the one that caused the patient to come to the hospital door today. Read the history and physical note to see which problem was bothering the patient the most. 69. What does the term hematuria mean when you see it in a urinary tract medical record? It means there is blood in the urine, which is a symptom of many different problems. If the doctor finds a stone or infection, you code those instead of the blood symptom. 70. How do you code a liver disease caused by drinking too much alcohol over many years? You use the code for alcoholic cirrhosis of the liver and add the alcohol dependence code. This combination of codes shows the cause of the disease and the current state of liver. 71. If a doctor performs a biopsy during a colonoscopy, how many procedure codes do you need? You need one code for the biopsy, and you do not need a separate diagnostic code. The biopsy is the bigger part of the procedure, so it covers the whole camera trip inside. 72. What is the difference between a screening colonoscopy and a diagnostic colonoscopy for a patient? A screening is done for a healthy person, but a diagnostic is done to find a problem. If the patient has symptoms like pain or bleeding, it is always a diagnostic test, not screening. 73. How do you code a patient with a feeding tube who is admitted for an infection? You code the infection first, and then add a status code for the presence of the tube. The feeding tube is a part of their daily life, so it is a secondary status code. 74. If a patient has a bowel obstruction, what is the most important thing for the coder? You must check if the obstruction was caused by surgery, or if it happened naturally today. Postoperative obstructions have different codes, so you must read the surgical history of the patient. 75. What code is used when a patient has a diagnosis of irritable bowel syndrome with diarrhea? You use the specific code for IBS with diarrhea, which is a very common digestive disorder. This code tells the insurance that the patient has a chronic problem with their daily digestion. 76. How do you handle a medical record that mentions a possible gallbladder infection, AT discharge? You code it as if it is a confirmed infection, because inpatient rules allow possible diagnoses. Inpatient coding is special this way, because doctors often treat things they're only fairly sure about. Thank you for finishing section 4, and I hope you feel like a coding pro. Please check the description box below this video, so you can buy the full course. Train, test, we need to fix, repeat these simple steps, and you will pass the exam. Welcome back to section 5, where we will focus on the skin and the musculoskeletal system. The musculoskeletal system includes your bones, joints, and muscles, which help you move around daily. A very common reason for a hospital stay is a broken bone, which we call a fracture. You must check if the fracture is displaced, which means the bone ends are not lined up. If the doctor does not say it is displaced, the coding rules say we assume it is. You also need to know if the fracture is traumatic, or if it is a pathological fracture. A traumatic fracture happens from an accident, like falling down the stairs or a car crash. A pathological fracture happens because a disease like cancer or osteoporosis made the bone every week. Never code a traumatic fracture code if the bone broke just because the patient is very sick. Pressure ulcers are another big topic for the exam, and they are also called bed sores. These happen when a patient stays in one position for too long, which hurts the skin. You must code the exact location of the ulcer, and you must also code the stage. Stage 1 is just red skin, but stage 4 means the bone or muscle is showing. If a patient comes in with an ulcer that gets worse, you code the highest stage. We also see many skin infections, like cellulitis, which makes the skin red, hot, and swollen. You must code the cellulitis first, and then add a code for the specific bacteria involved. If the patient has an open wound that is infected, the rules for sequencing might change. You should code the open wound first, and then code the infection as a secondary diagnosis. Always look for the word debridement in the surgical notes, which means cleaning out a wound. Non-excisional debridement is just washing a wound, but excisional debridement is cutting away dead tissue. Excisional debridement is a much bigger procedure, so it has a higher weight for hospital payment. You must read the description carefully, to see if the doctor used a scalpel or scissors. Joint replacements are very common surgeries today, like getting a brand new hip or knee. You need to know if it is a total replacement, or if they only fixed one part. You also need to know if the surgery is a revision, which means fixing an old replacement. Train, test, we need to fix, repeat the process until you can code these cases easily. Let us look at the questions for this section, so you can test your medical coding knowledge. 77. How do you code a fracture if the doctor does not say it is displaced or non-displaced? You must code the fracture as displaced, because that is the default rule in the book. The coding guidelines assume the worst case for bones, unless the doctor specifically says it is straight. 78. What is the difference between a traumatic fracture and a pathological fracture for a medical coder? Traumatic is caused by an outside force, while pathological is caused by a disease like osteoporosis. You must read the history of the patient to see if a fall or a disease caused the break. 79. How many codes are needed for a pressure ulcer that is located on the right buttock? You need 2 codes, one for the location of the ulcer and one for the stage. The location code tells where it is, and the stage code tells how deep the wound actually goes. 80. What should you do if a pressure ulcer is documented as unstageable by the nursing staff? You use the code for an unstageable pressure ulcer, which means the depth cannot be seen. This happens when the wound is covered by dead skin or a scab, so the stage is hidden. 81. If a patient has cellulitis of the leg and a skin abscess, which code is sequenced first? You code the cellulitis and the abscess together, using the codes found in the skin chapter. Usually, these two problems go together, and the code book has specific instructions for sequencing in both. 82. What is the key word to look for to prove a debridement was truly an excisional procedure? You must look for words like cutting, scalpel, or sharp excision in the doctor's operative report. Just washing or scrubbing a wound is not excisional, so the doctor must use a sharp tool. 83. How do you code a patient who is admitted for a total knee replacement for severe osteoarthritis? The osteoarthritis is the principal diagnosis, and the knee replacement is the principal procedure code. The disease is the reason thea here, and the surgery is the way the doctors fix it. 84. What do you do if a patient has a fracture and a separate pressure ulcer on their heel? You code both conditions, but the fracture is usually the principal diagnosis for hospital admission. Both conditions require a lot of nursing care, so they must both be on the final bill. 85. If a patient has a systemic infection from an infected skin wound, what is coded first? You code the sepsis first, because it is a life-threatening condition for the whole body. Any time sepsis is present, it almost always becomes the most important code on the entire list. 86. What is the code for a patient who has a history of a broken hip 3 years ago? You use a code for the personal history of a fracture to show it is healed. This tells the doctors that the bone might be weaker there, but it is not a new injury. 87. How do you code a surgery where the doctor puts a metal plate on a broken arm? This is a procedure code for internal fixation, which is found in the ICD-10 PCS book. Fixation means holding the bone still with metal, so it can heal perfectly straight and strong again. 88. If a patient gets a skin graft after a bad burn, how do you code the graft? You code the burn first, and then add a procedure code for the specific skin graft. The graft code depends on where the skin came from, like the patient or adenor person. 89. What does the term reduction mean when a doctor is talking about a broken bone surgery? Reduction means the doctor is pulling the bone pieces back into their original and correct places. This is the most important part of fixing a break, and it is a key part of coding. 90. How do you code a patient who has a site infection after a recent hip surgery? You use a code for a surgical site infection and add a code for the bacteria. This is a complication of medical care, so it has a very specific and special code set. 91. What should you do if the doctor says the patient has a possible bone infection, AT discharge? You code it as a confirmed bone infection, following the official inpatient coding rules for uncertainty. Osteomyelitis is very serious, so we code it as present if the doctor is still treating it. 92. If a patient has a mole that is being removed because it looks suspicious, what is the code? You use the code for a skin neoplasm of uncertain behavior until the lab results come back. Since we do not know if it is cancer yet, the uncertain behavior code is the safest choice. 93. How do you code a patient who has a stiff joint after an old injury from years ago? You use a code for the late effect of an injury, also called a sequela code. This shows the current problem is a long-term result of an accident that happened in the past. 94. What code is used for a patient who has a vitamin D deficiency, which makes bones weak? You use the code for vitamin D deficiency, which is found in the endocrine and nutrition chapter. This is a very common secondary diagnosis, especially for older patients who fall and break bones often. 95. If a doctor performs a total hip revision, what does that mean for the procedure code? It means the doctor is taking out an old artificial hip and putting in a new one. This is a much more complex surgery than a first replacement, so the code is different and longer. Thank you for finishing the 5th part of this course, and you are almost at the end. Please check the description box below this video, so you can buy the full course right now. Train, test, we need to fix, repeat these simple steps, and you will pass the big exam. Welcome back to Section 6, which is the final part of our Certified Inpatient Coder course. I am so happy you stayed until the end, because you are now ready for the finish line. This section covers the brain, the nerves, and all the complicated things that happen during childbirth. The brain is the control center, and a stroke is one of the most common brain problems. A stroke happens when blood cannot reach the brain, which doctors call a cerebral infarction in charts. You must look for the specific side of the body that is weak, like the left or right side. If a patient is right-handed and has left side weakness, we call that the non-dominant side. We also code epilepsy, which is a condition that causes sudden and repeated seizures in the patient. You must check if the seizures are intractable, which means the medicine is not working very well. Now let us talk about pregnancy and delivery, because these chapters have very strict coding rules. In the inpatient world, the mother's record is totally separate from the new baby's medical record. For the mother, the principal diagnosis is usually the reason she came in to have the baby. If she has a complication like high blood pressure, that code must be sequenced very early. You must also use a code to show the outcome of delivery, like a single live birth. For the baby, the first code is always about the birth, like being born in the hospital. You must check the baby's weight and how many weeks early the baby was born today. Prematurity is a very big deal in coding, because it requires a lot of extra hospital care. We also look for congenital problems, which are things the baby was born with from the start. Reading the birth record is the only way to get these codes exactly right for the bill. Lastly, we will look at injuries and poisonings, which use the S and T codes in the book. If a patient takes the wrong medicine by mistake, we call that a poisoning in the chart. But if they take the right medicine and get sick, we call that an adverse effect. These two things have very different rules, so you must read the doctor's words very carefully. Train, test, we need to fix, repeat the process until you are a master of these rules. You have worked so hard, and now let us finish with our last set of practice questions. 96. What is the principal diagnosis for a mother who comes in for a normal scheduled delivery? The principal diagnosis should be a code from the 080 bundle for a full-term delivery. This code is only used when the delivery is completely normal, with no other medical problems. 97. How do you code a stroke if the patient has weakness on the right side of their body? You code the stroke first, and then add a code for hemiplegia on the right side. It is very important to show which side is affected, so the physical therapists get paid. 98. What is the rule for coding a newborn's record for the very first time after birth? The principal diagnosis must be a code from category Z38 for a live-born infant. This code tells the insurance that a new baby was born, and it starts their medical history. 99. If a patient takes too much of their own heart medicine on purpose, is it poisoning? Yes, taking more medicine than prescribed on purpose is always coded as a poisoning event. We use a poisoning code and an extra code to show if it was an intentional suicide attempt. 100. How do you code a patient who has a seizure, but does not have a history of epilepsy? You use the code for a single seizure, instead of using the code fourth epilepsy disease. You cannot code a disease until the doctor confirms it is a long-term and repeating problem. 101. What does the term intractable mean when a doctor is describing a patient with a migraine? It means the migraine is very hard to treat, and the usual medicines are not helping. This makes the code more specific, which shows the insurance that the case is very difficult. 102. If a baby is born at 28 weeks, what two things must the coder report? You must report the prematurity of the baby, and the exact weight of the baby Ingrams. These two pieces of data decide how much the hospital gets paid for the expensive nursery care. 103. What is the sequencing rule for a patient who has an adverse effect from a correct drug? You code the nature of the problem first, like a rash, and then the drug code. Since the patient followed the rules, the physical reaction is the most important thing to report. 104. How do you code a patient who has a broken skull and a brain bleed together? You code the brain bleed as the principal diagnosis because it is more life-threatening today. Anything that hurts the brain directly is usually the most important thing for the hospital doctors. 105. When coding for a pregnant mother, what does the trimester information tell the medical coder? It tells the coder how many weeks the mother has been pregnant during this current visit. Most pregnancy codes require a final digit, which shows if she is in the first or last trimester. 106. What code do you use for a patient who has a suspected concussion after a fall? You use the code for a concussion, even if the brain scan looks completely normal today. Concussions often do not show up on scans, so the doctor's clinical exam is the main proof. 107. If a patient has a flu that turns into a brain infection, what is the order? You code the brain infection first, because it is the most serious and dangerous condition now. Encephalitis is much worse than the regular flu, so it becomes the main reason for the stay. 108. How do you code a delivery where the doctor has to use a vacuum to help? You code the delivery first, and then add a procedure code for the vacuum extraction. This is an assisted delivery, and the procedure code shows that extra help was needed today. 109. What should you do if a patient is admitted for observation after a very bad car accident? You code the specific injuries found, or use a code for observation for suspected trauma. If they are healthy, the observation code is used, but usually, we find at least one injury. 110. How do you code a patient with dementia who is wandering away from their hospital room? You code the dementia first, and then add a special code for the wandering behavior. This shows the nurses had to watch the patient very closely, which costs the hospital more money. 111. If a baby breathes in meconium during birth, what is the correct code to use? You use the code for neonatal aspiration of meconium, which is a serious lung problem. This often happens during a stressful birth, and it requires the baby to stay in the hospital. 112. What code do you use for a patient who is allergic to penicillin medicine today? You use a status code for the allergy to penicillin to warn all future doctors. This is a safety code, and it stays on the patient's record for their entire life. 113. How do you code a patient who has a spinal cord injury, without any broken bones? You use the code for the spinal cord injury level, like the neck or the back. The nerves can be hurt even if the bones are safe, and this is very serious. 114. What is the rule for coding a patient who is brain dead, but on a machine? You use the specific code for brain death, and keep the ventilator procedure codes active. This is a very sad situation, but the coding must be accurate for the hospital records. Congratulations on finishing the entire course for the year 2026. You have all the most critical and important information to pass your certification on the first try. Please check the description box below this video, so you can buy the full course as a PDF. Train, test, we need to fix. Repeat the process until you are the best coder in the world. I am so proud of your hard work, and I know you will be a great medical coder.